And following a subgroup analysis of men versus women, normotensive versus hypertensive, when the uric acid levels goes above certain levels, the risk goes up as the uric acid increases. Therefore, this suggests that uric acid may be a potentially modifiable risk factor for CKD. An increased uric acid significantly associates with the severity of afferent arteriolar sclerosis. And the next question is whether the changes urine levels are independently associated with eGFR changes. And in this rapid with underlying disease such as hypertension or 5 years, rosuvastatin did not bring about any beneficial effect. And even after looking at subgroup analysis, the authors were unable to find benefit. In dialysis patients, risk for cardiac arrhythmia and heart failure was deemed responsible. Then came the question of whether statin therapy becomes ineffective with worsening renal disease, and if so, at which stage? To this question. In this study, a total of 10,000 patients were recruited, and the majority, and 3,000 patients were on dialysis, and the remaining 6,000 were non-dialysis dependent CKD patients, and tested for the effect of cholesterol-lowering therapy. And after 5 years, a significant decrease in major atherosclerotic events with simvastatin and ezetimibe was observed. In the subgroup analysis, two things became clear. The first one is simvastatin and ezetimibe improve cardiovascular outcomes in mild chronic kidney disease not on dialysis. And the second point is combination treatment did not significantly reduce the risk of primary outcome in the subgroup of dialysis patients. And this is the recent results of a recent meta-analysis regarding lipid-lowering therapy. Both in terms of all-cause mortality, cardiovascular mortality, major cardiovascular events, or fatal or non-fatal myocardial infarctions, or fatal or non-fatal stroke, lipid lowering provided some therapeutic benefits in CKD patients not receiving dialysis. But it did not reach significance in dialysis patients, and the effect is unknown in transplant patients. And this is the summary of the second part. And treatment effects may vary with stage of CKD. And in persons not on dialysis, statins reduce all-cause and cardiovascular mortality and cardiovascular events in moderate high-quality evidence. For persons on dialysis, statins have little or no effect on all-cause or cardiovascular mortality or cardiovascular events. And the effects of statins in kidney transplant recipients are so far uncertain. And this is a recent KDIGO guideline on lipid management in CKD. And they note that coronary risk is sufficiently high to justify prescription of statins in people aged 50 or older with non-dialysis dependent CKD or kidney transplant. Thank you very much for your attention.
Thank you very much. We will call our fourth. Thank you. We are running short of time, so the question will be at the end of the sessions.
Sir, I am really honored to call our professor who has trained already many nephrologists from Pak Army as well, and they are also doing very well, sir. So Professor Mohammad Magdi Yaqub, who has been well known in all the circles of nephrology of Pakistan. He is Professor of Nephrology and Academic Director for the Department of Clinical Nephrology and Transplantation at Barts, NHS Trust and William Harvey Research Institute at Queen's Mary College, University of London. He is also Director of Diabetic Kidney Centre for East London and member of Advisory Board for Barts Life Sciences Center, Global Kidney Foundation, and Joint National Formulary for BNF. Sir, his topic is?
Thank you very much once again. Completely changing the topic from morning is for the senior citizens in the room. The first job of mine in United Kingdom, my first ward round, and that was St. Stephen's Hospital. Some of them would know in the room. It is now Chelsea, Westminster. So it's like me touching gold and turning into dust. I worked in that hospital. It's now knocked down and a new hospital has been built. Having said that, there was a guy called Ted Coombs, who was professor of medicine, and he is doing a ward round, and he is asking his registrar that why did you allow this patient to be admitted in my ward? I'm SHO, I do whatever I'm told. So he gave him a roasting because that patient happened to be 65 years and 3 days old. And the ward had a strict policy of everyone over the age of 65, even 1 hour older, goes to geriatric ward. That was 1983 in United Kingdom. And professor was very angry, my first day. And he turns to me and said, why this 65 years old age in the United Kingdom? Why above the age of 65 people turn geriatric? Anybody knows in the audience? Why 65 turns you into being geriatric? That is 1983, by the way. And luckily I knew the answer, and that is what you call luck comes the way, because that professor became my referee and then I got the jobs without any problems. So that's how the luck comes, that this was lucky. And that was the reason. Sir, it's frozen. Can you unfreeze it? Not going down. Right. Right, so this is the reason. And it's called Bismarck Law. And it was passed in France in 1883, which set 65 as the retirement age so the state can provide pensions and benefits to the people who are above the age of 65. That was, remember, Bismarck Law, 65, 1883. And that determines, in United Kingdom, the pension age. When I turn 65, I will get my pension. That age is going up, by the way, and there is a reason. So my professor was very, very impressed that I knew the facts anyway. But remember one moral here, that when that law was passed, the mean age of Europe, mean age of the population, was 44 years age. Majority of the people would die at the age of 44. That was the mean age of the population. Very few people lived to pocket the pension at 65. So 65 at that time was okay. It's fantastic. Very few people lived. When I was doing the house job, when this question was asked to me, the mean age in United Kingdom, survival, patient expectation or life expectancy was in women, in male is always lower than female. It was around about 65 and 70. 65 for females, 70 for females. Again, I would say it's all right. Bismarck got it right for 100 years. 50% of the people would die before the age of 65. Still, Another 50% would live long enough to pocket the pension. Already, government is thinking that we can't afford this pension. I'm coming to 2019 now. The mean age of survival is 82. There are more retirees than the people who are working in the job. State cannot afford to pay for all these pensions. So that's why pensionable age is going up in United Kingdom. It's 67, and there is every indication that over the next 10 years it will rise to 70. You will have to work up till 70 to pocket state pension. We have become the victim of our own success. We are living far too long. And unfortunately, we have expanded the life expectancy, but not the healthy life expectancy. The last 10 to 15 years, we are ill, and we needing not only benefits, but also we are clogging the beds in the hospital. So now the geriatric age has gone up to 75 in my hospital. So can you imagine from 65 to 75 over the period of 30 years? So now above the age of 75, people go to geriatric ward rather than 65. And this is the thing which is frightening the politicians. This is the projected figures. 2035, the people above the age of 80, they would be double than what they are now. At the moment in United Kingdom, around about 3.5 million people are above the age of 80. In 2035, expectations are that there will be 7 million people above the age of 80. The sad thing is that most of these people will be requiring heavy nursing care the way the trends are. So somebody will have to pay for it to look after these people. On top of that, as a renal physician, we know that our patients age very quickly. Our patients or our specialty is blessed with even a 40-year-old guy looking like an 80-year-old. And this is one of the data that if you have got end-stage renal disease and you are between the age of 35 to 44, your vascular age is the same as an 80-year-old in the general population with no renal disease. So a vessel of an end-stage renal disease, or heart of an end-stage renal disease patient who is in his 40s is behaving like an 80-year-old. Premature aging, acquired progeria. I remember when I used this phrase long time ago, I was told off by many mavericks in hemodialysis. But we knew for a long time, since I have become a trainee in nephrology, that the blood vessels of a dialysis patients are very stiff. They don't expand very well. They've got increased pulse wave velocity. And if you possibly remember and take an X-ray of a dialysis patient, it appears calcified arteries. It's called Monkeyberg calcification, if you remember from the initial pathology test books. That happens in old age, but our dialysis patients always have those. What is progeria? These are the two progeric children. They are 15 years old, and they look like, or their biological age, or the tissue age, is 80-year-old. And it's just a small accident of nature which has caused this problem. That there is a protein we call prelamin A, which needs to be processed to become mature lamin A by a zinc-containing protease. It breaks it down. Prelamin A becomes lamin A, very simple. In these patients, there is one amino acid, the substitution at the site of cleavage, so that enzyme which breaks it into prelamin A to lamin A does not happen. So this prelamin A goes and deposits in the nuclear bilayer membrane. So this nuclear membrane becomes very rigid. In a cell to divide, you need flexible nuclear membrane. If it is rigid, it won't divide. Definition of a senescent cell is inability to divide. That is a senescent cell. So this cell cannot divide, they can't grow, and they become old. Simple. Why I'm talking about this? Genetic. In renal failure, Kathy and ourselves have shown that the prelamin A is fine, there is no mutation. But the enzyme which breaks it down is downregulated. So still you get prelamin A accumulation in the membrane. So the cell doesn't divide. So you get senescence appearing at the age of 40 rather than the age of 70 or 80. If that was not enough, there's another problem in uremia, which we have shown. That our cells are the most eco-friendly cell. And those who are believers in this room would know that Allah subhanahu wa ta'ala has created us the most eco-friendly system in our body. Everything is recycled. If a cell dies, the cell membrane, the nuclei, the nucleotides, the proteins, everything gets recycled. That is called autophagy. That is the mechanism by which all the substances which are byproducts of a cell death are reutilized. And autophagy leads to cell division. If those substrates are not available, cell will not divide. So we looked at autophagy for the first time, and this is a uremic animal. So red is good, green is bad, other way around. This is a microarray of all the genes which are involved in autophagy. And our hypothesis was that not only prelamin A metabolism, but even autophagy will be impaired in uremia. And that's what we showed. That uremic heart, as compared to control heart, you can see everything is turned green. You don't need statistics for that. We didn't need it. Because every gene we looked at was screwed up, by the way. When we did in-depth finding of which important autophagy genes are up or down regulated, we have come to this conclusion. And we know now which one are the key ones, and we are working very hard. While we are doing this, we have come to a conclusion that when the cell doesn't divide and it becomes senescent prematurely, it does two things. First of all, it doesn't divide, so the cell regenerative power or the organ regenerative power goes away. But it does another silly thing, like what a very old, frail person does in the community. It becomes a burden on that tissue where it exists. This senescent cells makes low-grade cytokines. It creates inflammatory microenvironment. And that environment then stops the remaining good cells to divide. So I give an example to my trainees that if you have got a very old relative who comes to stay with you at home, very frail, and if you want to go on a holiday, you can't. You have to make an arrangement for somebody to look after that person. He is now stopping your normal life. He's become a part of your family. You have to think about who's going to look after it when you go on a holiday. The same thing happens in your body. Senescent cell is there, and it doesn't do anything itself, but it stops other working. And we are very glad to tell you that we have created an antibody, which is called senolytic antibody in our unit. And if you were to give that antibody, the senescent cells disappear. We just kill them. And the remaining cell starts working well. So you can restore youth back into a system by getting rid of the senescent cell. So there is hope for me and Professor Jafar Naqvi and other senior members in this team that we will be young one day. But I will use that antibody myself before I try it on anyone else. Let's come to the nitty-gritty, go away from basic science. Yes, basic science is working, we are progressing, and what I said, even 10% of that comes out true, believe me, it will change the life. I hope so. Let's see what's happening today, how we can look at our patients who are senior or not senior, that they are having a phenotype of an old person. How can we detect that? And there are very simple tools. One of them is this, you do frailty score. It was invented for geriatric patients, which I mentioned early part of my talk, but it's been now adopted in renal medicine. And we've done a lot of work on this. It's a very simple questionnaire. It just takes 5 to 10 minutes to do it and you can do it longitudinally. And you just look at 5 things and you score them from 1 to 5. So you speed at 8 meter gait speed. You make them walk for 8 minutes and measure how long they take. There is a spring, you can look at the grip strength. You ask question about exhaustion, weight loss, unintentional, and physical activity, which is a simple thing that what they do every day in life. 5 simple questions. And if it is, this total score is more than 3, then they are frail. Less than 3 are not frail. Simple, very simple tool. Using that, 75% of the people on hemodialysis as well as PD would be regarded as frail, irrespective of their age. There are other frailty indices, but the main important thing I say is that we use it a lot, surprise question. That if you're doing a ward round in your hemodialysis unit, ask a question with your nurses and older people, that would you be surprised if this patient will be dead in 6 months? And if the team suggests that no, I would not be surprised, that guy is at the end of the road. And we will hear from Professor Edwina Brown today in the afternoon in her plenary talk, how to care for such people when they're coming to the end of their life, how we can bring dignity in that phase of their life. Remember, life is a sexually transmitted disease. It always ends in death. You determine how you want to die. You will die one day, whether you want to die happy or a miserable death. You have to prepare for that. We never think about that. Let's see CKD. If you will look at this slide, you will be frightened that I'm telling you that there will be 6 million people in United Kingdom in 2035, and over 30% of the people would have CKD in that age group. Those people who have got CKD and they're above the age of 80 or 75, what happens to them if we were to follow them longitudinally? And that is done in Canada because they've got a very good database. And you can see that if you have got CKD and you're above the age of 80, you are 145 times more likely to die than develop end-stage renal disease. So if you are doing a dialysis, or you are a dialysis doctor and you're doing a pre-dialysis clinic, somebody's GFR is 15 or 20, fistula 1 first policy. Would you fistulate that person when you know that there is 145 times more likelihood that they will die before they ever reach dialysis? That is a question which we keep asking now because it is a personalized therapy, one unnecessary procedure. And if it is, why can't we just give them nurse-assisted PD? That's why you had so much talk about PD and it's underutilized in this country, and I personally think that that should be tried as much as possible in this part of the world. Another statistics, which is even more frightening, that if you have got, you are 80 and you have got CKD, whatever type of CKD, there is 30 times more likelihood than end stage to go into a nursing home. You don't have nursing homes. But in UK, we have got nursing home. We dump our loved one into a nursing home because we don't want senescent cell to become a burden on normal cells. So if people go on nursing homes and they go on dialysis, say for example a person who has got kidney failure is so frail he ended up in dialysis, can't look after himself. What would happen to him if we want to put him on dialysis? In America, for example, they advertise that we have got a nursing home where we can look after dialysis patients because we have got dialysis unit in the ground of the nursing home. So if one such study was done in America, mean age was 73, an estimated GFR of 70. They were all nursing home residents, by the way. And what happened to them? Within 3 months, 1/3 of dead. 6 months, 50% are dead. By 1 year, almost everyone is dead. At a GFR of 10, I can assure you in my supportive care clinic, I can get you 1 year of dialysis-free survival. There's no two words. What happened to those people who are in nursing home and they go on dialysis? Before the start of dialysis, they are very mobile and active. They become completely bedbound. So the quality is not only that there is no advantage in quantity, but the quality is going down. Would PD be better? If you have very old, frail person, you are borderline candidate for dialysis, would PD, which is less strenuous, less coming to the hospitals, would that be better? And that's Ken Farrington's data. And they compared hemodialysis and CAPD, and there was no difference. But they compared to a group who did not want dialysis. They lived less, but they were more satisfied. There was a mean life expectancy difference of 13 or 2 or 3 years. Unselected, younger population, you are going to live 3 years extra if you go on dialysis as compared to not going on dialysis. But those who don't go on dialysis die happy. That was the moral of the story in this paper. There are other papers, bigger studies, 44, 441. They compared those who went on dialysis and those who did not. Clearly, quantity advantage, no doubt about it, that you are going to live longer if you go on dialysis. But if you split that into 80 or above senior citizens, there is no survival advantage putting 80-year-old with end-stage renal disease or not putting them on dialysis. They've lived the same amount of time. But we know that the quality of life is better not being on dialysis. There will never be a randomized study. So we took upon ourselves to do a propensity match randomized small study. The group of people who we selected were in MDT, selected by all of us that they are not suitable, they're too frail, frailty score of 6, too frail. We didn't think that they will survive. But some of those patients' relatives insisted, like it would in an immigrant population, that even a day extra is good, because many relatives feel that even though, and they don't have to live because they just want a vegetable relative in front of them. So we did this, and you can see that in this group of people, at least our selection was good, that there was no survival advantage in those who they forced us to start dialysis. If you do have that choice given to the patient, then you need to have a very good supportive care program. You just can't just send that patient that I don't want to see you anymore, you're not suitable for dialysis. You are still responsible for that patient. And in order to improve the quality of life of the patient, you can do a lot of things. You can still treat the management of anemia, you can do bone and minerals, psychological support. In fact, my supportive care patients get better care than those who are destined for dialysis. It's ironic, because we have got Macmillan nurses, we have got community nurses, which we have developed a team. Everyone participates, and these people are very well looked after. So in our unit, we give them a choice, guidance from multiple team members, nurses. Everyone is important, nutrition, dietitian, pharmacist, everyone is important. And we give them a choice of quantity versus quality of life. Majority of the patient, in my experience, choose quality over quantity if the quantity advantage is less than 1 year. It's very simple, that if you give them that you live 1 year or so, but you'll have a poor quality of life, they always choose quality of life. And when you give them, you need to have very, very conservative treatment. Now, what about this? Data are emerging that 80-year-old people are getting dialysis. Transplants. Forget about dialysis. The results are very good. So in selected 80-year-olds, you can do transplant, because transplant is the best form of quality of life for renal replacement therapy. And this was the paper which put it all. It was an observational studies done in America principally, where they blew the myth that people with diabetes or older people don't do well on transplant. In fact, when they looked at it in an observational study, they found that the maximum benefit was seen in elderly and diabetic when they got transplant. That opened the floodgates in United Kingdom. Everybody went onto the waiting list. And we learned that transplant is very good, but for a first 6 months of post-transplant period, there is no survival advantage compared to staying on the transplant waiting list, because you have to take into consideration the anesthetic risk, the operative risk, the hospital risks. So the actual survival benefit starts after 6 months of transplantation. So if you want to transplant a patient, make sure that he's going to live at least 6 months to get the benefit. That's why we put so much attention into cardiac workup and everything. What about older people? Now, when these studies were done, it was 1999, data was from 1995. And everybody knows that American dialysis outcomes are worse than Europe by a mile. It's always been known. So this data was generated, survival advantage of transplant compared to people who were dialyzing in America. What has happened to that dialysis survival? Many moons forward now, I'm taking you, that even in America, dialysis results have improved, because they are not doing ultra-short dialysis for financial reasons or whatever. Things have improved in America. So if we were to do that data, which I showed you in elderly patient today, using the current dialysis survival against transplant survival in elderly people, what we will get. So a 70-year-old guy who's on the waiting list or gets a diseased kidney, his survival benefit starts after 3 years. He needs to live, or should have, 3 years in him to start benefiting the survival time. That's why when a 70-year-old guy comes to me asking for a kidney, I need to ask whether he would be able to live 3 years of this rigors of transplant and immunosuppression to take the benefit of that kidney, which is to improve his survival and quality of life. So transplant is not for everyone in elderly person. It should not be, it should be good, but it's not for everyone. It should be a personalized therapy. One size does not fit all. This is my bless them renal supportive care team. We call it supportive care because palliative care didn't go down well with our wards and my consultant colleagues. because palliative care implies cancer somehow or the other. So we called it supportive care, but said, these are the team, few members are missing from this, and everyone, psychologists, nurses, they are the angels, these two, dietitian, pharmacist, and the laziest of them is me. I just see the patient and just orchestrate the whole show. And this is the very touching thing we do. And I think it would be very, very useful if anybody wants to do this. So for the last 20 years, since I've become a consultant in my unit, we do a memorial service every year. And we celebrate the life of our patients who have died in the year before. And we ask their family members, whoever their relatives are, they come. We have got a great hall, which is an iconic hall in St. Bartholomew's Hospital. Is a great old imperial hall, which we get them all in one room. Every dead person's name is called out by senior member of the team. And we invite relatives to say a few words, not everyone, because hundreds are dying. We are the biggest dialysis program after Hammersmith, I think. So many people are dying, so we select few who come and say a few words. And also the feedback we get, which make us better clinicians. And this we have been doing it, and it is one of the most attended thing, and is now become the main calendar event of the year. It always happens in November, so when I go back, there will be a memorial service. We used to have it in September last year because of some clash in November, but it happens in November. So I said this in the morning: tell me and I'll forget, teach me and I may remember, involve me and I'll learn. Supportive care team is where we involve with every member of the team, plus with the families and their relatives. Not once, multiple times. And give them the dignity they deserve in whatever time they've got left on this planet. Thank you very much.
Okay, thank you very much. We'll go for the questions at the end of the session. And now, okay, sorry.
Can the gentleman have a mic, please?
I think I'm the only surgeon in this nephrology conference. Yeah. I'm the only surgeon, transplant surgeon you can say.
I can't hear you.
Should I keep it here? Right, this like this. I said I am the only surgeon in this nephrology conference, transplant surgeon, saying. You mentioned about dialysis and the age, and you cutoff point was 80 years. You mean dialysis, mean hemodialysis or peritoneal dialysis? I think peritoneal dialysis probably is not so invasive as compared to hemodialysis. We in young children and other weak people and sepsis and everything, we prefer sometime peritoneal dialysis, number one. Number two, transplant, we are not doing this cadaveric transplant, but if you have so many kidneys and the man with dialysis or with no dialysis, there is a match, and will you go for a cadaveric transplant for those people more than 80 years? You recommend that?
So, both questions very, very valid. Clearly, you need to do what is locally possible. Peritoneal dialysis, we do offer them, and we do have even nurse-assisted PD. So a nurse goes and does the PD for these frail people at home. But many people still consider that as an intrusion in their private space. So the culture in United Kingdom is much more independent-minded older people than what they are possibly here. So that clearly, if that works. For transplantation, when you said that a live donor, obviously I would not like a 40-year-old to give a kidney to an 80-year-old. I've got no objection. You can do transplant at the age of 80 because you will get some survival, but more importantly, quality of life advantage. But the reason why I'm saying this, that yes, you can do all these things, which is personalized based on your decision in that person. I'm not generalizing anything. I'm the last person to do that. But when, and particularly in this country, I am just trying to raise this issue, and there is now data coming, and that is the follow-up of 15 to 20 years, and some people based on that data are now projecting what would be like in live donors if they were to have 40 years follow-up. We don't have that 40 years follow-up yet. The mean is at the moment 11 or 12 maximum. And already some disturbing statistics are emerging.
Thank you very much, sir.
Can I have a brief question?
I would like to,
just one question, please.
Sir?
MD, I am really inspired by you, particularly the way you are motivating the audience for going for the questions against the opposition by the desk. So I really appreciate your motivation. And taking your motivation ahead, I am here to welcome you, because we met several months ago in Islamabad, if you remember, in Monal restaurant in Islamabad, where you spoke about the hyperuricemia, things like that. Well, basically I'm a clinical nephrologist, Professor Naveed Mohsin from Islamabad, and I have been working as a geriatrician, particularly with a special interest in geriatric nephrology abroad, particularly in Republic of Ireland. So I would like to share my experience and a few comments. I must say that the geriatric population, 65 and above, we all have the statistics of Eurotransplant program, which was well run a decade ago, where the patients who were 65 and above received cadaveric kidneys from 65 and above recipients, okay? So age is not a bar in general. Those who are between 60 and 75, they can be transplanted in inverted commas. But I must say, coming back to the palliative dialysis and my experience as geriatrician, we were offering dialysis in the acute conditions once we were stuck up with the acute fluid overload, once we were stuck up with the refractory hyperkalemias and very bad itch and pruritus and things, for a short term only, because we won't like to disturb the residual renal function of that guy. As you said that I would give 1 year survival to somebody who has got GFR up to 10 or something like that. So even the GFR between 4 and 5 GFR is sufficient for an elderly guy who's above 80 to give a respectable, decent life, rather than going and for complication of dialysis. So I must say that hemodialysis is should be behind the curtain. Now about the peritoneal dialysis, as my worthy colleague Professor Sadiq has pointed out, it has got the beauty of respecting the residual renal function, but unfortunately it's very expensive. And I was speaking to the federal minister just a week ago, and we are going to bring a few changes at the federal level as well, and we would like to go for the regulatory authority about the dialysis as well, and we will improve upon our vision about the cadaveric transplant. So I must say that now coming back to the transplant, the expanded criteria donor against the standard criteria donor, we can go for the expanded criteria donors, and we can put two cadaveric
excuse me,
kidneys
sir.
rather than one
Sir
cadaveric
Mohsin,
kidney.
We are
Thank you
going to
very
have this discussion during the lunch, and
Yeah,
if you
okay.
kindly,
Okay,
because
that's it.
we are
That's,
running short
that,
of
that
time,
was
sir,
my
and we'll
all views.
continue
Thank
with
you
this.
very much. I
And
took
I
your
could
point.
understand you
Okay,
are
thank
talking
you very
about
much.
the palliative dialysis.
Yeah, thank you very much.
Thank
Okay.
you very much. Sir, our next topic is, yeah, we can prevent kidney stones. It is to be done by Dr. Qamar Khan, who is working as a consultant nephrologist as VM Medical Center, Rensville, Indiana, and he is also currently working on establishing a peritoneal dialysis setup, which is going to be an addition to Muzaffarabad, Azad Kashmir of ours. So please welcome.
My pointer. What about my mic? Can you guys hear me? Yeah, because I have the lapel mic. Okay. What about the pointer? So where? So my time is already running out already. So. Yeah, okay, that's fine. So, well, my name is Dr. Qamar Khan, and I'm a nephrologist working in Evansville, Indiana. And I am a clinical nephrologist. I work for the VA clinic, and those who know, it is a government-run institution, and I usually or mostly deal with the CKD population, stone patients, hypertension. So my practice is mostly preventive care. So why are we talking about stone? I mean, stones are something, I mean, you think about it, the thing's so small, and it can cause so much problems, not just pain and suffering, but also it has consequences, and we'll talk about it in detail. And I'm going to fly over many of my slides because I have gotten quite a few slides. I wanted to cover most of the topic, and I may not do justice, but I probably will tell you one more thing before I go to the next slide. I have no disclosure, and I feel bad not having any disclosures, so I wish I had some. So this is me, and this is something that I really wanted to talk about just for a minute before I go to my talk again. So if this is a project that I have that I launched just a couple of weeks ago, this eMed Talks, that this is the address of web address of the talk, and this is going to be free. I have already uploaded a talk, and I've gotten some setup that speakers from not just nephrology but any specialty can come and just contribute to this project, and this is accessible by anybody all over the world. I mean, doctors, medical students. So initially we'll do some clinical things, and then we'll start adding some basic science, and we will have like short videos, and say for example PD catheter placement. So we can put videos on that thing. And this is the future. I mean, this is actually not the future, this is the present. I've been invited by people from Silicon Valley to kind of present my project to them, and after going back to States, I'm planning to go there and just give them this presentation, because they want me to kind of like, they want to give me the support, the IT support, but I actually don't need IT support. I formed the whole website, and I would encourage you to go and check it out. And this is a very simple way of doing lectures. So there's an app, it's called VoiceThread. So VoiceThread is, you record only on one slide, and then and you don't even you are not going to be in the picture. So you can just like be in your pajamas, and you can still record the slide. You can record it at different times, and if you don't like it, you erase it and you re-record it. And if you want to remove a slide or two, you can do that, and then you can add slides also. So this way it is easy to update the whole talk. So this is on line of up to date, something that you all use. We use it quite a bit, and it was up to date was started when I was a fellow at Yale. So I hope my professor, Professor Finkelstein, is not in the audience, because I'll be nervous giving this talk in front of him. Oh, you are? Oh my God. Oh God, I was hoping that you would not be. So, but anyway, so back then, Burton D. Rose, he started this up to date, and it was only for the nephrology topic, and my professors and teachers back then, that encouraged us to go and learn from that site. And now the up to date is the source that we go to for anything. So that said, and again, I mean, I was hoping that I would not go after such an eloquent speaker like Professor Yaqub, because I mean, I was, oh my God, the slides were so great, his talk was wonderful, and here I am like talking about my stone problem and with just very simple slides, but just bear with me, and then I'll go to the slide. And we were talking about dying. I would add one thing. I have this passion about bringing peritoneal dialysis to this country, or promoting it. It's already here. We have like people doing it very successfully. Dr. Qayyum's PD unit has many patients. There are patients in Islamabad. There's a PD practice that is going well. And I met the Senate chairman, Mr. Sanjrani, the other day, and we had a long talk. Professor Finkelstein, Professor Brown were with me, and we were asked to see the federal health minister, and we could not see him because we were driving from Muzaffarabad, and Muzaffarabad, it was a long drive. We couldn't get to Islamabad on time, and then but we have the PD unit all set and going in Muzaffarabad. It's going to be the first pilot project that will be launched in Pakistan, government supported. We met the health minister, Dr. Najib Khan there, and I think that this is wonderful. I mean, I tell you that, I mean, I know the stone, I'm here for the stone talk, but this is also very important, and maybe this part of my talk will be used for other nephrologists, to encourage other nephrologists in this country, and we'll get there, I promise. This is my passion, this is my life right now. So let me go to the next, let me go to my talk. So, well, this is a question, and I'll go over the questions very quickly. So simple question, recurrent kidney stone, which of the following would be the risk the person will be at risk for? So the answer is all of the above. So we think that he or she may have, maybe at risk for having like CKD or ESRD or coronary artery disease, but it is everything. So again, the prevalence is very high. I mean, in the United States, and I'll show you some slides that are studies that were done here at SIUT, but in states we have 15% of the people just kind of getting this stone problem at some stage of their life, and then we have in some part of the world, the incidence is very high. It all depends like how much fluid you're drinking and how much you're making. So some areas also they're consuming some things that make it even more like kind of frequent. So this is a pie chart. We know what kind of kidney stones are common, but we also, so the calcium oxalate we all know, but uric acid stones are, it looks like it's infrequent, but in our growing population with the diabetes and obesity, this is becoming the problem. This is like one type that is just growing at an exponential rate. And then others, struvite, cysteine, and calcium phosphate stone, and we'll talk about all kind of stones. So this is a paper. Dr. Rizvi was among the author, and Professor Rizvi, and he and you can see, I mean, if you see the numbers, and I won't go over numbers one by one, but you get an idea that how bad it is here in this part of the world, this kidney disease, like so many procedures, so many like patients going on dialysis. So same paper, I mean, if you see incidence of AKI 8%, so ESRD is 7.3, and mortality is high. So, and most of these patients, unfortunately, are living in villages, and those patients living in villages are the patients who don't get the basic health care. They live with pain, they live with infections, and they keep on getting worse. So what about the first stone? I mean, is this like a bad day, or is this just something serious? So it all depends. I mean, if you have a small stone that you pass, many people don't even bother like investigating these patients. But being a nephrologist, I hope that there are no urologists in the audience, but I think this is nephrologists who want to prevent the kidney stones. I mean, for urologists, it's their bread and butter. So I think that we should take charge and to prevent this thing. So again, recurrence it's so high. 50% of the people will have it by 10 years, recurrence. So you don't really take it that easy when you have it for the first time. And different studies have shown different results, but averaging 5% per patient per year is a pretty significant number. And again, as I said, that we have to have a multi-specialty kind of approach. So dietitians should be involved. Obviously, urologists will be involved, but I involve them only when there is a problem, when there is a need for lithotripsy, or if there's a need for removal of the stone, but not otherwise. So our job is very simple, and this whole stone management is very, very simple. I don't think that we should make a simple thing very complicated. It is simple, and you can do it. Anybody can do it. So what is the basic assessment, and who do you assess? So the question is that you cannot, with our resources, we cannot like do $1 million workup on everybody. So we just want to probably investigate patients who are having recurrent stone, but we should at least do a basic workup for most of the even first stone former, and I'll talk about it. But patients who have like required procedures, who even for the first stone, they should be investigated for sure. And diabetics, patient with CKD, coronary artery disease, CHF, and being on Qamar, and these are all patients with high risk. So earlier intervention, just like anything, is in my opinion, is better. So I do some at least basic. I mean, I do a little more than basic tests, but here you can at least do a PTH and some basic electrolyte test and culture, urine culture, and then depending upon the presentation, you can do a few more things. So incidental finding of a silent disorder. So many times you do a CAT scan for a different reason, and then you end up like finding a big stone. A small stone, you don't worry about it if it's one small stone sitting in the kidney. So you'll just wait probably. But if it's a big stone, more than 1 centimeter, 2 centimeter stone, sitting somewhere in the kidney, so you have an option. Leave it alone, or just go for some procedure. If the patient is, say, for example, pilot or operating heavy machineries, then you may want to and he or she may want to get rid of it. Then lithotripsy may be something that you might want to consider. So this is a very important slide. So active versus stone passers versus stone formers. So stone passers are, so if you have multiple stones and you started treating the patient and trying to prevent the stones, and the patient is still passing the stones. So now you are being seen as like, oh my God, this guy is treating me and I'm still passing his stone. So you have to kind of tell the patient that this is something that you may have. So you have to prepare the patient about future passing of the stones, that there are very few stones like uric acid stone you can dissolve, but other stones you have no really success in dissolving it. So there's the fate could be that they'll pass some more stones. So again, I mean, it's the same thing as the pie chart that I initially showed you, and so I'll just skip this slide. And when this is the most crucial part. of stone management. If you get the stone, you have to get analysis. I look for the stone analysis, and I call urologist office to try to get the stone if they have extracted it. And many times even they are careless about like getting the stone analysis. So I like this quote, I mean, give me your stone and I will tell you who you are. And it is not my quote, but I liked it. So let's go to the next case. And the gist of this case is that, I mean, this patient has been having recurrent stone, and then everything looks okay, but then you see that there are this amount of urine is 1.2 liters. So this person is like doing, say, for example, hot yoga. So the person is drinking a lot of fluid, but at the same time getting rid of the fluid through the sweat. And that person, you can do all these other good things, but the most important thing is increased intake of fluid. So this is the basic workup I usually do, a 24-hour urine collection. First time I do a cysteine check also, just to make sure that they don't have high cysteine, because the treatment for cysteine stones are a little different, and that's a one-time thing. And then I usually repeat another sample. So if you keep going from one sample to 2 samples, so your chances of getting a good result or some result that you can make sense of goes up. So as you can see that there are 20% of the cases you cannot find any abnormality in those patients. So no cutoffs. This is an important concept, that we like to have cutoffs. We like to have normal and abnormal. But in stone practice, you will see that different hospitals have different cutoffs, and you have like, it is all on a continuum. So if a patient has like 175 calcium in the 175 milligram calcium in the 24-hour urine versus 220. So yes, 175 is less likely to have stone, but at the same time, the 220, it's all like relative. So you don't exclude anything based on one number. But for people who want to have like cutoffs, this is just a rough like idea, and you will find these slides on my website and my lecture too. I mean, so I may not be able to complete my lecture, and I'll try to leave the stage right on time. So supersaturation, when you go back to your high school or middle school that you used to do chemistry experiment, you keep on adding things and things crystallize, and that's a simple concept, and that's how it is. And urine output is the key in most of the stones, not all. So I'll talk about it in a minute. So at least 2 liters per day is what we recommend urine output. So I'll skip this, but same thing. Desert, you have American soldiers like drinking 17 liters of water and then they're still making urine because the urine output was low, sweating a lot. Compliance, as always. Specific gravity is an important way of determining if the patient is drinking enough fluid. So low specific gravity, less than 1.010 is what we aim for. pH is important, urine pH. So simple information, high urine pH may be a calcium phosphate stone, low urine pH may be calcium, so maybe uric acid stone. So this is another important slide I would like to point out, that CT scans are done, fine thin slice, like thin cuts, 5 millimeter or less, gives you pretty good information. I don't do the ultrasound for investigating these stones, and KUBs are okay, but not good for initial evaluation, maybe for follow-up. And then there are low dose CT scans that are being done in the United States with very little exposure, almost going close to the KUB. And one thing that you want your radiologist to really give you, that you cannot accept them saying that, okay, patient has bilateral kidney stones. So yeah, well, you have to tell me how many stones, what are the sizes, and what are the locations. Then the last thing is Hounsfield unit. I mean, nowadays you can, just based on CAT scan, you can determine probably guess at least what kind of stone. I mean, very dense stone like maybe cysteine, or a very soft stone like uric acid. So remember, uric acid stones are radiolucent, so you'll miss it on CT. So again, this case, so everything pretty much is normal. The patient doesn't want to go on any medicine. What would you do? So I mean, this patient is a female and she is at risk for osteoporosis, bone fracture. So we try to treat the patient, not just the number. So this patient, I mean, the answer is like increased calcium intake, because the calcium will bind the oxalate. Oxalate is the culprit. I always ask my patients if they are drinking tea. A lot of patients love tea, just like us. I'm waiting for my first stone to happen. Seriously, I drink so much tea that I'm afraid. I have not gotten myself investigated, and I am scared to. But that's tea. That's the first question that I ask. So myth. People consuming large amount of vitamin D, people think that vitamin D is bad for the stones. It's not true. So there was a study done in which they gave like unreal dose of vitamin D, ergocalciferol, 50,000 units to women every day. I don't know how they were able to convince those women to take it that high of a dose, and they could not find any increase in calcium excretion in the urine in those patients. And this is just calcium oxalate monohydrate, the bigger one, and on the left, the envelope shaped as a dihydrate. So again, you can see the risk factors, and I'm not going to go in detail. Many times you don't find anything wrong. And this is my most busy slide. And somebody said to me one time that if you want to really make people miserable, just put a slide with so much that they cannot even read. So this is like a death by slide. So, but bottom line is that the low calcium is very, very important. There's a whole mechanism that you may be able to understand if you read the whole thing later on my lecture in the website. Pause it and read it, and then you will see how it promotes. It used to be that uric acid stone was thought to be the nidus, and then the calcium oxalate would build on it. That was a wrong theory. So calcium phosphate is what it changes from monophosphate to diphosphate, and that's what becomes like it goes and erodes the papilla, and the calcium oxalate builds on it. So many times you find a stone with an eccentric nucleus of the calcium phosphate. So 5% calcium phosphate, 95% oxalate. So hypokalemia again causes hypocitraturia. I still 30 years in the United States cannot speak so many words I cannot say right. But anyways, this is what you should really keep an eye, because you don't want people to be hypokalemic. And amiloride is one medicine, and the reason I'm bringing it up because I'm talking about basic physiology, that this is something that you need to keep in mind because it blocks the ENaC channel. There is a channel in the tubule, distal tubule, that this medicine blocks. And when it blocks, then sodium cannot go in. And that's when the sodium does not get into the, it's an epithelial sodium channel, so it does not get into the cell, then there is a positivity that is generated in the lumen, and it pushes the calcium into the cell, and it causes low calcium in the urine. So that's how it, but the clinical data is a little lacking, but it makes sense. And sometimes when you use chlorthalidone or some thiazide diuretic to prevent these hypercalciuric stones, then this medicine you can add, and that will help. Fasting calcium level is important. It's very rare to find hyperparathyroidism with normal calcium levels. So very rare to have normal calcemic hyperparathyroidism. So you want to rule out these, at least some of these common problems. So urine sodium, an independent risk factor. So I mean, higher the sodium intake, the more calcium that patient starts spilling. So you need to keep that in mind. So again, some of the medicines that you need to keep in mind, common one is Topamax, and the rest are not that common, but you need to keep them in mind. And insulin resistance, again, causes low ammonium production, and I mean, it can lead to stone formation, and it's the uric acid stone. So what is the empiric treatment? So you prescribe 3 liter of fluid, tell them to eat good, healthy eating, low animal protein and high, less sodium, less oxalate. And the potassium citrate, 20 milliequivalents twice a day is probably a good dose. Start with 10, go to 20, and chlorothalidone if they are hypercalciuric. So what is best? Among these, money is an issue here, but if you can afford, chlorothalidone is a long-acting, and that's what I prefer. Start with 12.5, you can go up to 50, and you can even go to 100. I don't go very high dose, but hydrochlorothiazide is a short-acting for all of the young fellows here. It is not a long-acting diuretic. It has to be given twice a day. Dark side of thiazide, again, hyponatremia, hypokalemia. Hyponatremia is common because you're giving a chlorothalidone and then you are asking the patient to drink tons of fluid. So it puts them at risk. So lemonade, everybody thinks that you drink lemonade and you'll be fine. But no, it is not that true. You have to drink 6 liters of lemonade to make it somewhat equal to 10 to 20 milliequivalents of potassium citrate tablet. So again, RTAs and chronic diarrhea, you have to ask them about chronic diarrhea, very important. And again, I already talked about it. So uric acid stone, we talked about diabetics, and metabolic syndrome is what? It's an epidemic. So it's there also, and now I'm with the great food that we have in Pakistan, it had to happen, one day. So we are having a problem with obese people and having diabetes on the rise and so many things. So again, this is a case, just the take-home point is, the case is uric acid stone. But the take-home point is you don't give allopurinol to these patients. You just have to make their urine alkaline, and that's all it is. You just use potassium citrate. And so I'm not going to go over the whole thing, but the alkalinizing the urine takes care of pretty much all the uric acid stone problem. It's extremely rare that you will need allopurinol, and obviously dietary intake is important. So again, fish and chicken count, so they should have more veggies and so calcium phosphate is an important stone because it is formed in patients with high urine pH. So keep that in mind, just simple thing. And the treatment, it is very tricky to treat these stones, calcium phosphate stones, because you give them potassium citrate, it increases the urine pH, and that is not good. But it also helps to prevent potassium, the calcium phosphate stone formation. So we have to need to monitor the pH and not let it go too high. So incomplete RTAs is one of the causes. And then these are again, not very good data on B6 fluorogen. And bariatric surgery is becoming common, and it's a fat malabsorption. It's saponification of the oxalate that we worry about. So cystine stone, very hard to treat, and I still have a couple of minutes. Is this right? Okay.
We're running short of time, so
yeah, just last slide. So staghorn infection related, very common here and very difficult to treat. So I'll just wrap up here, and I'll just go to my take-home points. Again, stones are with consequences, can be prevented. For recurrent kidney stone, at least do a couple of 24-hour urines and urine analyses, and stone analysis give very valuable information. Uric acid stone should be kept in mind. Alkalinization of the urine is all that you need, and potassium citrate works for most of the stones. And then you have this chlorothalidone that should be preferred over hydrochlorothiazide. Ureteroscopic removal of obstructing stone has become the gold standard. Very fewer people are getting SWOL or lithotripsy. Pus under pressure is a urologic emergency. So is the unilateral kidney with a stone in the ureter. And that's it. Thank you very much.
Dr. Tufail from City of Faisalabad. I practice nephrology. Excellent review of the subject. Can you go back to the slide where you said 40% hypercalciuria? Others, please. Slide showing different percentages of stone formers,
Okay. So
hyperphosphatemia. It was studied on 24-hour urine collection.
right.
The point I want to make is that this data that he has given does not strictly apply to population in Pakistan.
That may be very
I-
true. Let me find the slide first and then.
Yes. Yes.
Yes.
See, most of the time what you are referring to is idiopathic hypercalciuria.
But this is the
Idiopathic-
data from the
most of the
United
time,
States.
Just forget it. In Pakistan, I did a study myself. Ali Jafar Naqvi and his team did study in the 1970s. I did my in 1980s. Out of 128 patients, I could not find a single patient with idiopathic hypercalciuria. Most of the metabolic abnormality that we come across, apart from stones mixed due to infection, is hypocitraturia, hypocitraturia,
Right.
hypocitraturia.
And that is a point well taken, because I mean, and that's what I also said, that the citrate, potassium citrate,
Thank you very
generic
much.
treatment, which works for many different kind of stones, even the calcium. So we also don't see too many patients hypercalciuric. And as I told you, there's no cutoff. So that's what we also don't have, like those cutoff lines that this patient is hypercalciuric, this patient is not. So as I mentioned in one of the slides, that thing is like almost going away. So
Okay, thank you, Qamar. We are going to invite our last
you.
presenter for this session. Is Professor Mary Richards. Mary has over 30 years experience of working in an executive management role and senior faculty roles with the healthcare and education globally, including UK, Australia, Africa, Middle East, especially in UAE, Palestine, Lebanon, and Bahrain. So she's going to present the nursing leadership and the renal nursing development experience to the building to build the capacity. Thank you.
Okay, thank you. Good afternoon, and thank you, Mr. Chairman, and hello, ladies and gentlemen. So we've had a very interesting session this morning, and we've heard a lot about all of the challenges facing us in kidney care globally. The majority of that has largely been around interventions and discussions around what nephrologists can do. I'd like to spend the next 30 minutes talking about what nurses can possibly do and how we can develop nursing expertise to build capacity. Okay. Okay, thank you. So to start off, I'd like to begin with a story that some of you may be familiar with. It's an old story by Irving Zola, and it's called The Upstream and Downstream Story. And I've chosen this lovely river in Pakistan to talk about it. But the story, as I tell it, goes that there's a doctor and a nurse standing on the banks of the river. I don't know how to do this. They're standing here on the banks of the river here. And they're having a chat, and then all of a sudden they see this person come down in the river, screaming and shouting, drowning, clearly drowning. The doctor jumps in immediately and saves the patient, saves the person, brings them out onto the bank and starts to resuscitate them. Less than a few minutes later, another person comes down the river, screaming and shouting, waving and drowning. The nurse jumps in, pulls the patient out, pulls the person out and onto the bank and starts to resuscitate them. This happens on and on for about the next 15, 20 minutes. More and more people are coming down the river, clearly in distress and about to drown. And the nurse and the doctor take it in turns to jump in and save them. After a period of time, with all these people laying on the bank of the river, the nurse gets up and walks away. And the doctor says to her, where on earth do you think you're going? You can't leave me at this point. And she says, well, actually, I think I'm going to walk further up the river, up here, and find out why everybody keeps falling in. I think it's important that we think about all of those issues in terms of upstream and downstream and the impact that they can have on what we're trying to do, and they're certainly essential for building capacity. My slide's not moving. Okay, thank you. So in terms of building capacity, we talk a lot about it these days, but what do we actually mean? Well, it's about having an ability to achieve our goals effectively, having strategies to identify and secure the resources that we need to succeed in what we're trying to do. It's about information and often education, developing resources, financial management, and also organizational learning, instruction, and guidance. And critically, it's about leadership development. If we're going to build capacity, we have to have people that are going to be leaders who can drive change and push things forward. So basically, it's any set of actions that an organization takes to improve its ability to perform successfully in its chosen area. It's really important because it encourages leaders to evaluate their own abilities to perform in a very complex environment. And as we've heard this morning, particularly in relation to some of the issues around kidney care and CKD particularly, that's important. So things like the early detection of CKD would be a prime example of trying to build capacity and looking for ways to manage a complex environment. So you need to look at ways that the organization, or indeed the individual, can develop staff so that they can provide new services that enhance programs and services. Traditionally, professions in healthcare have worked not so collaboratively necessarily in terms of for capacity. So some examples of how they might have worked historically are around coexistence, so rather separate functioning, professions working within their own silos and doing their own thing. Maybe some cooperation, so saying, well, yes, I think that's important, but I've got to do what I'm doing first, and then maybe I'll look at what you're doing later. Coordination, maybe thinking that people need to adjust what they do to avoid overlap and confusion, but still not really collaborating wholly. But when we look at things like collaboration and co-ownership, that's quite different. If we're looking at true collaboration, we're saying, let's work on this together, and let's be responsible about the outcomes together. If we have professional integration, it has massive benefits for collaboration and co-ownership. So we get an increased reach to the population, so we have massive impact, a greater critical mass, strengthened negotiating power, new and effective ways of doing things, greater flexibility, and also shared costs. Quite often when it comes to initiatives for capacity building, people will worry about it and think that it's going to cost more money. But in fact, when you pull all of these things together, it's quite amazing to see quite often that they are actually cost saving. In terms of nursing leadership, nurses have been involved in capacity building for many years, and if we look really historically, we can remember Florence Nightingale, and everyone will remember her story of working in the Crimean War and actually being the founder of modern nursing. Now, Florence had absolutely no previous experience of war, but she was a highly educated woman. When she went to Crimea, she wasn't particularly popular with her medical colleagues. This was a bit of a busybody and interfering quite a lot. But during her experience, she became quite an expert nurse practitioner in terms of clinical practice. She also became an expert administrator. She noticed that it was important to pull together all of the issues around management of services, making sure that resources were available, staff were available, etc. She was also a highly skilled statistician, and collected meticulous data and analyzed it. And it was through those activities that she managed to transform clinical practice in the Crimea, which led to breakthroughs in clinical practice, particularly related to infection and mortality, knowledge, skill, and application to practice. She was an absolute formidable force for change, and she had a continuous pursuit in excellence in nursing. If we fast track to 2019 and look at leadership in healthcare today, we can see that it's in fact a $366 billion industry. 95% of organizations across the world invest in leadership development for their staff, and most of it fails to deliver the results that they expect. The reason for this is the lack of context mostly. Leadership programs are developed very generically without looking at the context of the organizations people work in. There's too much reflection, poor understanding of culture. And when I talk about culture, I'm not necessarily talking about culture of where people live or where they come from, but also organizational culture and the culture of professions. And also in terms of data, it's important to understand that what gets measured gets done. If you can't measure it, you can't manage it. And leadership programs need to ensure that that is included. So leadership, many of the programs that you will see that are offered in organizations are transformational leadership, servant leadership, organizational leadership. Basically, everything that they talk about, everything about leadership is about change. It's just about seeing a problem. It's about seeking opportunities for change and being comfortable with it, using examples from sectors not necessarily your own, and prioritizing what's important. What's important isn't always what's the most urgent. Listening to others and influencing others, transforming ways of doing things. So in our steps to capacity building, first of all, as professions and interdisciplinary, we need to agree a need for change and identify between ourselves the strengths and weaknesses that we need, and evaluating internal and external factors. We need to make sure that we have leadership enhancement of management structures, processes, and procedures to meet present and future needs. And this is about systems leadership. So it's not just about one single organization, it's about understanding the impact of that on others. Because consequently, capacity building is a very long-term process. And it's quite common that as you make improvements in one area, you'll get problems in another area that require attention. This is the law of unintended consequences. So as a consequence, capacity building requires that we have commitment and perseverance. So why is all this important in kidney care? Well, we've all heard this morning about the data on the global burden of CKD. In other halls, they've been talking about the increasing prevalence of AKI. We need to develop services to manage these burdens because what we have is not meeting those needs at the moment. There's a massive complexity on the demands of our roles, management of patients on renal replacement therapies, and also more upstream activities like nurse practitioners in early detection, home therapies, and even things like putting renal nurses into places like critical care to identify risk of AKI, etc. In 2017, the ISN came up with a global kidney health roadmap for closing gaps in care. They identified 10 themes to enable that to happen. In order to make it happen, the proposed activities included education, research, policy creation, etc., among many, many other interventions. And this was all targeted at healthcare institutions, government agencies, industry partners, so all very upstream, but also clinicians. And I've put that in red here because by clinicians, I'm not talking about, even if that's what was intended at the time, I'm talking about clinicians as being everyone involved in kidney care, so all members of the multidisciplinary team. World Nursing in 2019 is a very challenging place to be. There's been a big move towards an all-graduate profession, and that's coming back again because we know that we have an absolutely massive shortage of nurses globally, and also of doctors. There's been a massive lack of investment in education and training. And then in response to all of these things, there have been many extended roles or changes in roles of professions. So nurses have been trained to absorb some of the task-related activities of doctors. There's been a rise of technician-type roles for nurses. And nursing has traditionally focused on the doing part of these. So you can see here these three domains. This is cognitive. This is about your education and your knowledge and what you know. This is your psychomotor. This is your skills and what you can do. And this is the affective. And this is about your development and also your approach and your attitude to the way that you work. So we've always focused mostly on this, the psychomotor training. And neglected some of the underpinning knowledge and development of behaviors that best support practice. But it's important also to know that when programs focus too much on the theory at the expense of practice, then that is also a weakness. The fact that educated nurses are necessary in terms of good outcomes for patient care is well documented. And this was just a study that was done and actually produced in the Lancet. So that was very important for us as nurses. But you can see here that a study that was done in 300 hospitals across Europe. And the workload bit is important, but the bit that I want to draw your attention to here was that for every 10% increase in bachelor's educated nurses, decreased mortality by 7%. So therefore, a hospital with 60% of bachelor's nurses caring for 6 patients would have a 30% lower mortality than a hospital with 30% of bachelor's nurses. So having educated nurses with high level of expertise makes a difference. In the UAE, where I've been working for the past 8 years, when I first started, I did a comprehensive learning needs analysis of our nurses working within kidney care. And at that time, they were working mostly within hemodialysis. And they were very skilled technically and very able to do their jobs. But they were very lacking in their underpinning knowledge. And really worryingly, they lacked any confidence at all to discuss or challenge. So 49% of the nurses didn't feel confident to challenge any clinical decision made by any member of staff who was senior to them. So this is important in terms of making sure that we get good care. As a result of the learning needs analysis and many other metrics that were measured from that, we started a master's, a specialist renal nursing master's in 2014. At that time, that was the only master's course in the United Arab Emirates. We partnered with De Montfort University in the UK. And importantly, this program was very different from any other program that had been run before. In terms of it was very much based on clinical expertise and leadership, not administration and management. We were very clear we didn't want nurses going through a 2-year program, putting a certificate on the wall, and then staying in an office doing administrative tasks. This wasn't a management master's program. It was about clinical practice. So all of the learning was embedded in clinical practice. Our first cohort graduated in 2016, and it was really about growing the nurse leaders of the future for sustainable kidney care. This is just an example of the program and how it looked. So it covered absolutely everything about renal care, kidney care. So not just dialysis. Dialysis was a tiny part of it. So our nurses graduated from this program being able to do advanced health assessments on patients, having gone through leadership programs in context of kidney care, and being skilled researchers. These were the places where we made sure that they had to go and get clinical experience. So they did placements in all of these places. So the nurses had to come out of this program having understood and worked with patients from dialysis to transplantation, vascular access surgery, and critical care as a few examples. For the nurses in the audience, you'll be familiar with Patricia Benner's model of moving from novice to expert in clinical practice. And our nurses all started the program around the competent or advanced beginner level. When they had completed, they were all up here in either proficient or expert level. And it's at this level here where you get nurses who are able to take on leadership roles and can be real forces for innovation and change. We showed a massive impact in our program to demonstrate how important it was. These were just some metrics. They're not really that important, but these are some metrics that were used to measure our performance within the organization. And you can see, well, back in 2012, we were not achieving any of our targets in terms of clinical outcomes, and we were benchmarking against STOPS, which is on the right-hand side. By 2018, we were achieving all but one of our targets and exceeding DOPS in several of them. Nothing had changed except that we had educated our nurses and changed the way that they practice. So I think it's important that when you do these things that you can measure the impact of what you're delivering. As a result of the program also, our nurse-led initiatives that have been started, because those nurses who developed high levels of expertise were able to then, in their own right, go on and lead and develop services. So nurses that completed the program led a vascular access program. I'll be talking about that tomorrow and the great outcomes from that. A nurse-led CKD early detection program, and a nurse-led home therapies program. So this is all about building capacity within that country. In terms of clinical practice and moving education within two different cultures and different organizations, this gentleman here was one of the senior managers in our organization who enrolled onto the master's program because he wanted to do a master's degree, but was very reluctant to get back into clinical practice. He'd spent his whole career trying to get out of it and was very happy doing administrative tasks. I assured him that the only way he was going to really be able to develop as a leader within the organization in terms of nursing was to get his scrubs on and really understand what clinical care and delivery is all about. And he did. And I think he was very grateful and ended up being one of our most successful nurse leaders. There are many nursing leadership models, and most of them really don't meet the mark. I've made up my own, and my leadership model just involves these 4 core components, which are knowledge, skill, courage, and care. When we talk about care, it's about not forgetting to care about the patients, not forgetting to care enough to support, advocate, and develop and promote our other colleagues, managing productivity, and having a good vision for the future about always thinking that things can be better. In terms of skill, it's time working clinically. I can't overemphasize how important that is at all levels, no matter how senior you become, and valuing the clinical aspect of your role to inform decision-making, being a role model, and having first-hand experience of what it's like on a day-to-day basis for the front line. In terms of knowledge, you must always commit yourself to ensuring that your clinical practice is underpinned by up-to-date evidence, being expert and familiar with research, thinking, and trends, and learning how to learn, ensuring that you always pass on the good stuff, not old recycled stuff, and definitely not Wikipedia. And courage, having the courage to believe in yourself. As nurses, I think sometimes we get a little bit intimidated and we don't have the courage to do that. You have to stand up for your patients. You have to stand up for your colleagues. You have to engage your colleagues in difficult discussions and influence and drive change. And most importantly, you have to have the courage to fail, because you will sometimes, but it's always about learning. This is another slide to show that since the program that we started, and including some in-service education, this is the number of hours of education delivered across the bottom. And this was our crude mortality. And so back in 2012, you see our crude mortality of our patients was just under 11%. And after 4 or 5 years of the program, our mortality had fallen to under 5%. So the importance of collaboration cannot be overestimated. We have to work interdisciplinary and truly interdisciplinary education and cooperation. Sometimes it feels a bit awkward in the beginning, but it's vital to find like-minded people. It's important that our doctors understand they can't do this capacity building all alone. And nurses, you need to understand and speak up. You need to join professional groups, join societies, or your own. Reach out to a mentor or be a mentor. The ISN itself has been, as I've mentioned in the roadmap, building capacity and developing lots of programs, most importantly, the educational programs for nephrologists. But I'm delighted to say that back in 2016, this was expanded and now includes nurses for the first time. So we now have a nursing and allied health task force within the ISN called the Kidney Health Professionals Working Group. And that is now the nursing leadership and voice within the ISN. And so far we've had 2 publications. We now have a nurse on every regional board in the ISN, and nurses leading educational ambassador visits. These are just some slides of one of the educational ambassador visits that we were doing. Again, building capacity. This was in Kenya. Okay, this is a little cartoon that I think speaks volumes about when you're trying to convince organizations and professions about building capacity through expertise. There are some that get it, some that don't, and some realize that there is nothing to get. So back to my river. Last night I think we all agree that we need to build capacity. And to build capacity, we need to develop expertise. I was hugely inspired last night by the stories of your esteemed professors who have been working hard right up here at the top of the river and developing kidney care in Pakistan. As from this quote up here by Isaac Newton, they truly are giants. But you know, nurses can be giants too. Thank you very much.
Thank you very much. This concluded our third session of the day, and we will request the presenters to come here so that we can give them the shields.
I will request Sir Magdi to kindly come forward and give shields to the
presenters.
I would request Professor Magdi Yaqub sir, please you have to distribute the shields for this session. So you can please, if you can come forward. Sir, down here sir on the stage. Yes. First I would request the chair of this session,